Hello, and welcome to Dialogues in Obesity, where visionaries meet to lead the change. I'm Rachel Deer. This program is supported by a grant from Boehringer Ingelheim Pharmaceuticals Incorporated. The grant is for scientific and educational purposes only and will not promote Boehringer Ingelheim Pharmaceuticals products directly or indirectly. Our learning objective is discuss the rationale for using obesity pharmacotherapy and review current obesity medication options available in the U.S. And now, I'll turn it over to our host, Karli Burridge, a board-certified PA and is a Master Fellow of the Obesity Medicine Association. Karli is the co-founder and past president of PAs in Obesity Medicine and also serves on the board of the Obesity Medicine Association and the Illinois Obesity Society. She is the founder and CEO of Gaining Health and is the director of clinical education at Healthy for Life in Naperville, Illinois. Karli, take it away.
Thank you, Rachel. Welcome, everybody, to this episode of Dialogues in Obesity. I'm your host, Karli Burridge, and this podcast is designed to empower primary care providers to feel confident, well-informed, and supported in delivering obesity care within the time and resource constraints of a primary care practice. I'd like to introduce our guest for today, Dr. Marc-Andre Cornier. Dr. Cornier is the chair of diabetes and director of the Division of Endocrinology, Diabetes, and Metabolic Diseases at the Medical University of South Carolina. He has focused his career on cardiometabolic diseases such as obesity, diabetes, and lipid disorders, and is an active clinical and translational investigator with a primary research interest in body weight regulation and studying optimal interventions for weight management and metabolic health. He is also actively involved in clinical trials for investigational treatments for lipid disorders, diabetes, and obesity. Dr. Cornier has been an active volunteer and leader in a number of health-related associations and currently serves as the president of the Obesity Society. Mark, thank you so much for being here with us today.
Hi, Karli. Thanks for having me. Thanks for the invitation, and thanks for the warm introduction.
Absolutely. I'm so glad you're here, and I'm really looking forward to our conversation today. So let's start off by telling our listeners a little bit about the purpose of today's podcast episode and what we'll be discussing today.
Yes, so we'll be talking about obesity pharmacotherapy or obesity medications. What's the role? What are the options here in the United States? The good, the bad, the ugly, and future directions as well, if we have time.
Okay, perfect. So let's start off with discussing what is the rationale for using medical therapy to treat obesity. So explain to us why advising our patients to simply eat less and move more is insufficient.
Well, what's critical and at the core of all this is that overweight and obesity, basically having excess or abnormal body fat or adiposity, this is a chronic disease. And we know that it's associated with altered neurocircuits in the brain that promote excess food intake in the environment that we're in. And so it's very difficult for people to lose weight and maintain that weight loss with just changes in their diet and activity, because the signals that tell you to eat actually go up and are enhanced when we lose weight. So medical therapy can really help people, first of all, kind of basically impact the cause of their obesity, reversing it, leading to weight loss. But again, we're not treating a weight, we're treating the disease obesity. And this leads to important clinical outcomes and helps individuals maintain that weight loss long term. And that's why this is a very important part of our treatment paradigm when we're dealing with the disease of obesity.
Absolutely. We're really addressing the biological underpinnings of this disease, and pharmacotherapy can play such an important role in that.
Absolutely. That's better said than me.
Not at all. But so when we're thinking about who would be appropriate candidates for obesity medications, who would those people be, and how can clinicians identify those patients in primary care?
Well, traditionally, we had approval for using medications for obesity in individuals with the diagnosis of obesity. And traditionally, that was diagnosed when your body mass index was over 30 or higher, or in individuals who had overweight with a BMI of 27 or higher if they had weight-related complications or comorbidities. There's been a slight change in some of the FDA approval here in the US where we're not using necessarily those BMI numbers, but saying diagnosed with obesity. And that's a whole other discussion about how we diagnose this and identify obesity. But so individuals who are at higher risk based on their diagnosis of obesity or excess body fat with complications are candidates. That's a lot of people. But I think what's also important is that people have tried other methods for weight loss. They've tried a diet, they've tried exercise, they've tried behavior modification, and have not necessarily succeeded. And so now we really want to intervene. But at the same time, we don't want to wait too long. I think we wait till patients have significant obesity, they have significant complications before we even start thinking about it. So we really do want to treat people at an earlier stage.
Absolutely. And how do you think is a good way for primary care providers to kind of bring up that topic? Do you have a method that you recommend for initiating that conversation?
Yeah, I think first is you as the provider have to identify that the patient has obesity. So on the chart, there's going to be a BMI, but until you actually write it in your note or dictate it in your note that they have obesity, it's not identified. So you have to identify that their weight its trajectory is going up, their BMI is starting to rise, they have an elevated waist circumference, or what other methodology you use. And you've assessed that they have complications or they're at risk of complications. So now you want to bring it up with the patient. They didn't come to see you to treat their obesity. They didn't come to get help for weight loss. So many of us recommend that you ask the patient first. You ask permission. Mrs. Jones, I've noticed that your weight has been trending up and your body mass index is in a category now that you have obesity. Is it okay if we talk about your weight? I think using language like that can be very helpful in getting the idea. And then we start talking about it as a disease, as a chronic disease associated with risk, et cetera.
Absolutely. And I think that's so important. What you mentioned is asking the patient for permission, kind of respecting that patient autonomy. Maybe on that day, it's not the right day for them to talk about it, but at least you've opened that door. And
right.
If they come back at another visit, which is the great thing about primary care, is we often see our patients, for many years. And so it opens the door for that conversation when perhaps they are ready to discuss it, if they're not ready to discuss
right.
it.
And many times they haven't even thought about it,
Right.
And so they need to be educated a little bit about why would there be a concern before we could even start talking about treatment options.
Yes. And you mentioned something really important. You said it starts with documenting the BMI and documenting the diagnosis of obesity. And we know from the data that obesity is significantly underdiagnosed and undertreated. So why do you think that is? And also, why do you think it is that many patients who do start treatment don't stay on treatment long term?
Right. Well, I think the reason it's not brought up, the reason it's not on the chart is multiple. One is it's complicated, it's a long discussion, but many primary care providers are not trained in how to manage obesity. And so they don't even want to bring it up. There's a lot of bias. There's a lot of stigma involved in this. It's a long conversation. It's complex. So we need to educate our primary care providers on all aspects of obesity, but that it is a long-term chronic serious disease. I think there's many reasons. We did an audit of our own charts in endocrinology and found that only 40% of patients with diabetes in our clinics who had a BMI over 30 actually had a diagnosis of obesity. So we as specialists aren't even identifying it in the chart. So that is step one, because if we don't identify it as a problem, we're not going to treat it, right? So that's important. Now, your second part of that question was, why aren't patients staying on treatment long term? So first of all, we're not identifying people, so we're not treating people. Some of the older studies suggest that only 2 to 3% of people are actually getting medical therapies. Maybe those numbers are a little bit higher now with some newer agents. But then if a patient does start on treatment, by 6 to 12 months, most of the patients will not be on these medications anymore. And there's many reasons for it. A big reason is cost. If these medicines are not covered, patients can't continue to pay for these expensive treatments, and so they will stop it. Well, a big part of it is this lack of education, lack of knowledge that this is a chronic disease that needs to be treated like a chronic disease. That once you take the treatment away, the weight comes back. The obesity is still there. And then finally, there are people who stop the treatments because of side effects, and that is a part of what we deal with in any chronic disease, in any treatment. There's the benefits and risks, and certainly there are some risks involved.
Absolutely. And I think, a lot of the clinicians you mentioned, there's a lack of education for most healthcare providers on obesity, which is certainly true. And that's one of the reasons why we're doing this podcast, right? But I think most providers and patients are aware of some of the new injectable medications that have come on the market in recent years. But many people may not be familiar with some of the other treatment options. So can you review which types of obesity medications are currently available in the United States?
Absolutely. So we're fortunate that in the United States, we have access to just about all the obesity medications that are available. Some of the older treatments that are, and we'll start with the medicines that are available for long-term use, because that's the whole goal, is a long-term. So there's a really old one called orlistat, which is a fat blocker. That's the only one that doesn't work on the brain to help people lose weight. There's a medicine that's a combination of two drugs called phentermine and topiramate. Together at lower doses are better tolerated. And we actually see pretty good weight loss, on the order of about 10%. Naltrexone bupropion combination is another FDA-approved medicine that also is associated with a modest amount of weight loss and has its role. And then we get into the injectable GLP-1 based therapy. So we have liraglutide, which is a daily injection that's been around for some time, initially for diabetes and then for obesity treatment. And then came semaglutide, that was well known for diabetes as the medicine Ozempic, but then sold for obesity under the name of Wegovy. And then most recently was tirzepatide, which is a GLP-1 and another hormone GIP agonist, also approved for diabetes as Mounjaro, but then for obesity therapy as Zepbound. There's a medicine called setmelanotide, which is really only approved for very rare causes of genetic obesity, but an amazing treatment for those patients when they're identified. And then just briefly, we also use a medicine by itself called phentermine. It's available in a generic form, so it's very inexpensive. And while it's only FDA approved for 3 months of use, that was approved in 1959 when we had a different view on obesity and weight management. Many people use phentermine long term, and I think the safety has shown that it's okay to use this medicine long term if your state regulations allow you to, because that's a critical piece. So that gives us quite a few different options. Yes, people are walking in the door saying, "I want Ozempic," right? So what they mean is they want semaglutide, and maybe we have a discussion, and at the end of the day, they can't afford it, and their insurance isn't going to pay for it. So then we turn to some of these older medicines that some of the brand name ones are available for around $100 a month, which is much more affordable. And I said then there's also some generic formulas as well.
Yeah, I think thank you so much for that great overview, because I think it's important for people to know that there are other treatment options out there other than the injectables, even though those are the most effective. But like you said, there can be so many barriers in terms of cost and access to care, potentially side effects. So it's great that we have more tools in our toolbox for
Absolutely. And the other thing is, while these newer therapies might lead to more weight loss and have shown more clinical benefits, not everybody needs to lose 15, 20% of their body weight to get medical, clinical benefit. 5, 10% can have significant benefits on someone's health. So I think we need to have that in mind as well when we're picking and choosing treatments. Treat to target type of approach is something to be thinking about.
Yeah. And I think also, as you mentioned earlier, not waiting until somebody has a very severe form of obesity with severe complications before we intervene. If we can intervene earlier, then we may not need as much weight reduction in those patients, and we may not need to pull out the big guns, if you will, for treatment.
Exactly. So it's that mantra of treat obesity first. Intervene sooner, earlier, before people have that long list of problems on their diagnosis list, and treat them big early, and it'll make everybody's life a lot better.
Absolutely. So, you told us a lot about the medications and about the weight reduction, the average weight reduction that we're seeing with some of these medications. But can you also share some of the other clinical benefits that we've seen with some of these medications?
Absolutely. So, what are the cardiometabolic benefits? So, first on glucose. So, we see pretty much with just about every agent that's available, we've seen diabetes prevention in people with prediabetes, and the more weight loss, obviously, the better that effect. And our newer therapies, the GLP-1s, we know treat diabetes, so they're very effective. Tirzepatide recently shown well over 90% reduction of diabetes in people with prediabetes. In those with diabetes, again, A1Cs go down. With some of the older agents, we might see a 0.5 reduction in A1C, and with the newer ones, more weight loss, more benefit on the A1C. We see other cardiometabolic risk markers that are improved. So blood pressure improves, lipids improve, specifically triglycerides and HDL. Markers of inflammation improve. Liver fat and steatosis improves, whether it's MASLD or MASH. It's pretty incredible that we can actually see fibrosis reduced with these treatments. I always thought fibrosis was a permanent thing, but no, we can actually improve fibrosis in the liver with these treatments. And then we have cardiovascular benefits. So we've seen with tirzepatide and semaglutide improvements in heart failure related outcomes. And then with semaglutide, we actually have a cardiovascular benefit overall, which is very exciting. First time we've seen that with medical therapy. There's non-metabolic outcomes that are important. People talk about metabolically healthy obesity. Well, those individuals who don't have metabolic disorders still have mechanical issues and risk for cancers and other things. So, there's a study that shows semaglutide improved osteoarthritis knee pain, which is fantastic. And these studies also show improvements in physical function and quality of life. And now we also have data showing improvements in obstructive sleep apnea. So pretty dramatic clinical benefits for patients.
Absolutely. And
in fact, in the United States, not everywhere in the world, we have some of these drugs that are FDA approved, not for the treatment of obesity, but to treat cardiovascular disease or to treat liver disease or to treat sleep apnea.
Absolutely. It's really exciting to see these increasing indications coming out for these medications. And just almost every day, it seems like there's new studies coming out about some of the other health benefits that we're seeing aside from weight reduction and obesity treatment with these medications, which is really exciting. And so all of that sounds really amazing, but it's also important that we talk about potential side effects and safety issues. So do you want to talk about that a little bit?
Yeah. I mean, if we focus in on the newer agents, the GLP-1 based therapies like tirzepatide and semaglutide, the most common side effects are nausea, vomiting, constipation, diarrhea, some more gastrointestinal in nature. People get reflux. They can get, well, with any weight loss, you can get gallstones. So, so certainly from that perspective, to try to improve that, we start low doses and we slowly titrate. The FDA indications say you titrate every 4 weeks, but often in our clinical practices, we'll titrate slower if someone's having some problems with nausea and vomiting, especially. And those effects tend to improve over time. And the studies show that the bulk of the symptoms are early on, and over time, things get better. That's the main issues with side effects. Some of the older drugs, have issues with concern for increase in blood pressure or heart rate. Certainly with phentermine, we worry about more stimulants side effects. With topiramate, brain fog or paresthesias. So there's certain, every drug has its certain side effect profile that you have to be aware of. All these drugs are contraindicated in during pregnancy, regardless of which drug, because we're not supposed to be recommending weight loss during pregnancy. And certainly there are other contraindications for each of these drugs.
Yeah. And I think that's why it's important that, especially when we're starting people on new therapies, that we follow up with them regularly, especially if we are up titrating the medications, and make sure that we're providing counseling around managing side effects. A lot of times there's nutritional changes that we can recommend for patients, like eating, smaller meals, avoiding high fat foods and stuff like that can really mitigate some of these side effects. So I think as long as we're, guiding our patients and following up with them regularly.
Right. And that's critical. Patients on these drugs need close monitoring. It's not just write a prescription and say, see in 6 months or a year. People need to be monitored, and that's part of the comprehensive care that we must deliver to patients to be safe. These are very powerful drugs, especially with the newer agents, and so this needs to be done in a safe manner.
Absolutely.
And that brings up a couple of other potential concerns that are not as common. There's questions for thyroid cancer specifically. It's medullary thyroid cancer. Someone who has a papillary or follicular thyroid cancer, there's not a contraindication to these treatments. We don't need to do baseline ultrasounds or thyroid blood tests, despite what social media will tell you. That's not indicated. Pancreatitis is a confusing one. So certainly someone who's had a history of acute pancreatitis in the past, we may not want to start one of these medicines. But I just reviewed a paper today that in patients with diabetes on a GLP-1 based therapy, no increased rates of pancreatitis compared to other diabetes medications. So I think that's a question mark. There's been some pop-up of some ophthalmologic issues, and so we're still again trying to get more information on that. And then there's some concerns about losing lean body mass or muscle mass. Anytime we lose weight, we lose fat, but we lose some muscle. And no matter how you lose weight, that's what happens. And there's some questions about whether with some of these newer therapies, do you lose more muscle than you would have expected for the amount of weight loss? It's, in my opinion, the data are not clear on that. And so, it is something that we need more research on. On the positive side, even if people are losing muscle, their functionality improves, and their pain improves, their metabolic health improves, all things that we see or would think about with less muscle mass and sarcopenia. So I think from a good news, we do see clinical benefits. So that I think that's still to be determined. There are a number of drugs that are being evaluated and studied that might prevent muscle loss or even increase muscle loss, which might be a good thing. Or who knows? Maybe that's not a good thing. We'll have to see with time.
Yeah, there's still a lot of research that we need in that area. But, that kind of brings me to the point around lifestyle counseling. Because certainly, we're looking at the research of this on muscle mass loss and things like that. But, what are some of the things that we can do from a lifestyle perspective in terms of advising our patients on nutrition and physical activity that can perhaps help mitigate this muscle loss, or at least, help the function and the quality of the muscle and the strength of our patients? What are some dietary and exercise recommendations that you?
Yeah, I think these medicines are so powerful, so it's almost like we don't need to counsel patients on caloric restriction, which is what we've always been doing. What's really more important is quality of diet. So we want a healthy diet with lots of fruits and vegetables so that you get your minerals and vitamins and all that, but we want to ensure adequate protein. That's really important. And it's some of these patients will go on these medicines and they say, I don't eat anything. Right? Well, you still have to eat something. You need to get some protein. So that's really important. And hydration is important. So fluid intake, especially if there's issues with nausea, vomiting, we want to make sure people still stay well hydrated. And part of the lifestyle side of counseling is physical activity, right? And so the more the better. And when we were more focused on weight loss, we used to really promote more aerobic exercise, because for bang for your buck is you're going to burn more calories. But I think we've learned more and more that resistance training is probably very important, and even especially in this setting when people are losing weight quickly. So now we don't have a lot of great research to support this, but it's certainly common sense, and studies are being done. So we'll have more information. So quality diet, a good amount of protein, hydration, and exercise with a focus on resistance exercise would be really what I would recommend, or what I do recommend to my patients.
Absolutely. Same here. And I think it's just important that we have that discussion. It doesn't need to be an hour-long discussion, but we need to be touching on asking our patients what they are eating on a daily basis, kind of figuring out what their understanding is as far as nutrition and how to even know how many grams of protein they're getting a day. So helping them with some of that counseling. If we have access to a dietitian, especially if a patient needs a lot more education and counseling in that area, that's amazing. But I also think that we as clinicians, if we can get a little bit of training in some of that basic nutrition guidance, that would go a long way, and the physical activity as well. So thank you so much for that. And so this kind of leads me to my question. You already addressed it a little bit in terms of this is a chronic disease, but probably the number one question we get from patients and oftentimes also from clinicians is, how long do people need to stay on these medications? Are we treating them indefinitely?
Right. And I think that really points at the bias and stigma associated with obesity, right?
Yep.
We would never ask that question if we were treating a patient for type 2 diabetes or for hypertension or for depression or hypercholesterolemia. It's interesting that a medication like semaglutide, tirzepatide, those drugs are indicated for diabetes. And when we prescribe them for diabetes, never once have I had a patient ask me, well, when am I going to be able to come off of this medicine? But the minute I use the same exact treatment for obesity, that's the first question. How long do I need to take these medicines? So what we know from studies is that on average, when you stop the medicine, people regain the weight. They may not at 6 months or a year, maybe they haven't regained all the weight, but they're on that trajectory. Does that mean everybody regains all the weight? No. There's going to be outliers. There's going to be individuals who will be able to maintain their weight. They're rare, but they're out there. It'd be nice if we could predict that, so that we could feel comfortable stopping a treatment, knowing that they're going to be okay. But most people are going to regain weight. And so it tells us that, and it's not a surprise. If I treat someone for high blood pressure and I put them on a medicine to lower the blood pressure goes down. It doesn't keep going down. It stabilizes, right? Just like weight. And then if we were to stop it, what would happen? The blood pressure go right back up, right? And so same thing with obesity. So we really have to change our mind frame about this as a chronic disease. So it's us, the providers, that need to be thinking about this differently, but how we educate our patients about this, because for them, they lose the weight, boom, they're done, and I can stop it, right? And unfortunately, then next thing you know, they've regained the weight. So, what we don't know though for sure how to handle this. Do we just keep people on these medicines indefinitely? Is this a forever thing? Do we try to lower doses? Do we try to, if it's a weekly drug, do we try to go every other week? We don't have research to really support any of these things. We're doing this as clinicians, but we need research. And there is research that's being done currently to say, how do we handle this long-term, weight loss maintenance? In fact, if you look at some of the older medicines that we used to use, like the phentermine, topiramate, the weight loss might have been 5-10%. But what was amazing is when you follow patients 3 years, they've kept that 5-10% off. Yeah. With diet and lifestyle, people always regain the weight within 6 to 12 months. So quite powerful. So we need better strategies to deal with this. In my mind, it might be that we use one drug for weight loss and a different treatment, a different medical therapy for weight loss maintenance, potentially. Maybe there's a less potent, easier to take, less expensive treatment that we could do for the long haul. So a lot of research that is needed in this area.
Absolutely. And I think in the interim, until we have some of that data to guide us, I think a lot of us kind of take this on an individual basis, right, with each patient and just see how are they doing on it. A lot of patients may need to stay on the therapy and on the dose that they were at to lose the weight in order to keep it off. And some patients you may be able to de-escalate. And so, until we have some of that research, it's really kind of taking it on a case-by-case basis. And I think very important if you do have a patient who is trying to either de-escalate or maybe a patient who's trying to get off the medication, that we follow that patient a little bit more closely, explain the biology to them, as you mentioned at the beginning of this podcast, so they understand why it's so hard to keep the weight off once they have lost it, that it's not a matter of willpower, it's not their fault, it's biology that's fighting that. And then make sure that we're following up with them regularly again. So if we do see that the increase in the weight, or we do see that some of their complications are coming back, that we, get them back on therapy.
Right. We don't want to wait, until they've regained all the weight and then some, and, there's people say, oh, and then they regain weight, it's all fat. Again, I don't know that there's great research to support those type of statements, but certainly there's concern. People say, oh, not only did I regain weight, but I regained more than, well, potentially that might have just been your trajectory. And you just caught back up to where you would have been had you never started the treatment. So we want to have a short leash and follow these people closely and get them back on treatment ASAP if they start regaining.
Absolutely. Absolutely. So, we talked about so many amazing medications that are currently available, but this is a very exciting time in this field. So can you tell us about, potential new therapies coming down the pipeline? And, what do you think about some of these new therapies? May they be more effective or easier to take? Or what are you kind of seeing right now?
Yeah, it appears that from a timing perspective, the next set of treatments that we're going to have available to us are oral GLP-1 based therapies. There's 2 of them that appear to be pretty close to approval. One that is, semaglutide, available in oral formulation. We have that for diabetes at a higher dose for obesity. And another is a what's called a non-peptide a GLP-1 agonist that is easier to absorb and easy to take. These, may be associated with a little bit less weight loss than the injectable agents, but might be easier to take and also cheaper. That would be, an important factor there. If you look at the pipeline, that's probably the next thing that we're going to see. So maybe oral formulations. Then we have all these other injectable therapies that and other orals, but where industry, our pharmaceutical industry partners are studying, other dual agonists. So receptors for glucagon, for example. and others are triple agonists, a GLP-1, GIP, a glucagon. And then we know that amylin receptor agonism causes weight loss. And now we have these long-acting amylin analogs that people are studying either alone or in combination with other GLP-1 based therapies. So a lot of excitement. We have, oral agents. We have more, weekly agents. We have some that are monthly. And, even, at Obesity Week, we, heard on some data on maybe an every 6 to 12 month RNA-based therapy, so really exciting things happening in the field. And we're due to have which I think is good for our patients, more to choose from, more tools in the toolbox, as you mentioned, which also may drive costs down because there'll be more competition within our industry partners. So that's always potentially a good thing. And there'll be a role for all of these agents. And as I mentioned earlier, there's also quite a bit of investigation in terms of treatments to help preserve or enhance muscle mass and lean mass, which either alone or in combination with other weight loss or obesity treatments, I think is potentially exciting as well. There are also a pipeline of drugs that impact inflammation that's associated with obesity that might really be beneficial for the metabolic health of individuals. So a lot going on here.
Yeah, it's certainly a very exciting time in the field. And as you mentioned, it's just so great that we have potential treatment options coming in the pipeline for patients. We know that not everybody responds to every medication. Everybody responds differently. There's really not one form of obesity. There's obesities, right? There's so many different causes and different receptors for different patients that they respond to. So it's great to really have a great armamentum of treatment options for our patients. So it's certainly an exciting time. And I want to thank you so much for this excellent discussion around pharmacotherapy for obesity today. So to wrap things up, do you have any key takeaways for our listeners?
Yes. I think at the core of all this is the simple statement: obesity is a serious chronic disease. Until we get past that, we're not going to get anywhere. So the fact that we're not initiating therapies, we're not even identifying the disease, or when we do treat, patients stop and thinking that the disease goes away. So we really need to get the core of the biology and educate pretty much everybody, right? It's our patients, the public health, it's our providers, but then it's also the policymakers, the payers of healthcare really need to get on board with this concept that obesity is a disease, and it meets every definition of a disease. So that's really key. And when we're treating medical diseases that are chronic and are due to a specific cause, well, let's target that cause. And that's what these medications do. They really do impact that appetite dysregulation that people have that lead to obesity. And these medications are if tolerated, are very effective. People have significant improvements in clinical outcomes, whether it's prevention like diabetes, or actual treatment and reduction of cardiovascular disease, sleep apnea, those kind of things. So it's still not just medical therapy, though. We still need to have lifestyle counseling be part of our treatment. We have to consider obesity-related procedures like metabolic and bariatric surgery as important options. And this is a comprehensive. It's not just us prescribing a pill or an injection. It's also working with dietitians and nutritionists and exercise specialists, mental health specialists. So it truly is important to have a multidisciplinary approach.
Well, thank you so much, Mark, for this great conversation around pharmacotherapy.
Well, thank you, Karli. It was a pleasure spending the last half hour with you and great discussion. And I hope it's helpful for our audience out there.
Absolutely. Rachel, back to you.
Thank you, Karli and Dr. Cornier, for a wonderful conversation. And thank all of you for watching. We'll see you next time.